Hey everyone, today I'm going to give a talk on the influence of anesthetic agents on the ischemic brain. I'll start off by discussing kind of what ischemia is and what we can do to prevent any further damage to the ischemic brain. And then I'll go into discussing different medications and what their actions are on the ischemic brain. So as we're all aware, ischemia is when we don't have enough oxygen being supplied to an organ to allow it to maintain the function that it's there to do. So for cerebral ischemia, that's when we just don't have enough perfusion to the brain or a certain area of the brain to maintain neuronal function. So there's two different types of cerebral ischemia. The first is global cerebral ischemia. So this could be due to things like cardiac arrest, where complete global ischemia with no blood flow to the brain, or from things like sepsis or severe hypotension, where you're just getting much decreased blood flow to the brain, causing incomplete global ischemia. Things that we more often deal with, especially in neurosurgery, is focal cerebral ischemia. So this is when you have a certain artery that has been occluded or a certain area of the brain that has received damage that's not getting oxygen to it. So in this, we have two areas. We have the area that has taken the direct insult, the severe ischemic area, and this is the area where the neurons die very rapidly, and most of the times we can't get function back to this area of the brain. The area that we're more concerned about is the penumbra, which is the area around the severe ischemic area that has not enough blood flow. The cells are going to die, but if we can provide more blood flow soon, we can prevent the ischemia to this area and prevent the death of the neurons in this area. So the goals that we try and accomplish when we're dealing with an ischemic brain are obviously to reduce the degree and the duration of the ischemia. So like I was just discussing, trying to decrease the insult to the penumbra so that we decrease that severe ischemic area. Things that we can do is obviously get blood flow back to the area, whether that be from surgery or from giving medications. All we want to do is try and get blood flow back to there as quickly as we can. For us as anesthetists, we obviously want to maintain our physiologic parameters in a normal range. So we want to avoid things like hyperthermia, hypo or hyperglycemia, high CO2, low oxygen, and obviously really decreased blood pressures. This will help reduce the ischemic damage that occurs by having the most possible oxygen going to the area as possible. We also want to prevent seizures or prevent any more seizures in patients who are already experiencing seizures, as well as avoid high ICP. So we want to make sure that we have good cerebral perfusion pressure. So if we have high ICP and we have maintained our normal MAP, we're obviously going to decrease our cerebral perfusion pressure. So we want to make sure to keep that above 50. Through that, we want to make sure that we're having good blood flow to the area. Blood carries oxygen, so we want to make sure that the blood flow to the area is at least about 20 mils per 100 grams of brain per minute. And then we want to make sure that the oxygen being supplied to the brain is 30 to 35 at a minimum, preferably higher. Things that we can influence, like I previously discussed, is avoiding hyperthermia, as this increases the metabolic rate of the brain's requirement of oxygen. Hyperglycemia and hypoglycemia, as this can exacerbate ischemia. Hypotension, like I previously discussed, you want to make sure that you're getting good blood flow, and you want to make sure that you're maintaining your cerebral perfusion pressure. So you don't want your mean arterial pressure to decrease, as it will decrease your CPP. Hypoxia, obviously, if we're hypoxic, we don't have the best possible oxygen in our blood to be delivered to the brain. And then hypercapnia, we want to avoid that, as high CO2 causes higher ICP, and it makes it a lot more difficult to maintain perfusion in a good CPP. So there's a few conditions that require resuscitation and protection. Resuscitation, so things that the brain has taken a major hit. So if you have a traumatic brain injury that you can't operate on, you want to resuscitate that brain. Non-hemorrhagic strokes, cardiac arrest, these are things that there's not much we can do surgery-wise, but we can try and resuscitate as much of the brain as we can. Protection, so surgeries that we perform, we want to make sure that we're protecting the brain as much as possible. So anything that causes increased ICP, so whether that be from a tumor, so you have increased brain tissue, if you have hydrocephalus, you have increased CSF, or if you've had some sort of brain injury or stroke where you have a significant amount of blood in the brain, you want to try and protect against this. Anybody undergoing any sort of intracranial procedures, so whether they have an ESM or they're having a tumor resection, you want to make sure that you're protecting the brain. So the medications that we use / other medications and the ischemic brain. Really the only medication that has been proven through research to improve outcome from ischemia is recombinant tissue plasminogen activator, or rtPA. There's evidence to show that if TPA is given to patients with an ischemic stroke within 3 hours of the stroke occurrence, that they have much better outcomes. Further research has actually been done. In some situations, if you have a patient who comes in outside of that time frame, or if they're from a rural community and they don't make it to your center quick enough, they have done some research to show that this can be expanded in certain cases for 4.5 hours. As you can see here, the dose is 0.9 mg/kg, with an important note that the max dose is 90 milligrams, which is important in our more obese population nowadays, as we don't want to overdose them. Medications that we use, so anesthetics in ischemic brain, have a lot less evidence as to their benefit in ischemia, brain ischemia, and only small clinical trials have been performed on humans. So most of the evidence that has been shown has been done on animal models. So it's unclear if they really do influence clinical outcome in humans or not. So we'll go over the medications that are good to use in cerebral ischemia first. Propofol, a medication that we all use daily, is quite good for the brain as it decreases the oxygen consumption, the blood flow, and the ICP, allowing the brain to kind of be in a more restful state. It does this by having GABA-mediated decrease in neuronal firing, so you don't have as much oxygen requirement in the brain. It's also shown in animal models to protect against focal ischemia, and as we all know, it is a good anticonvulsant, so it protects those seizures that we want to avoid. As we're all aware, when using propofol, we need to make sure that we avoid any significant hypotension, as this will decrease our MAP and therefore our CPP. So it's important to have other agents to modify blood pressure when using this medication. Another very useful medication are benzodiazepines. So similar to propofol, they decrease our brain oxygen consumption as well as the cerebral blood flow. ICP is really mostly unchanged with these medications. Like propofol, they maintain the vasoregulatory response of changes to CO2. So you can still use your CO2 to modify your ICP and cerebral blood flow, so you can hyperventilate the patient and decrease their CO2 to try and decrease some of the ICP. Like propofol, it also has very good anticonvulsant activities, so it can be useful for that. And in patients who are awake, it's very beneficial for anxiolysis, which can cause an increase in their blood pressure, cause an increase in their cerebral blood flow, so we can reduce that blood pressure as much as possible. Should be noted that in patients who are awake, it's important to monitor for hypoventilation, which can cause hypercapnia if we're not ventilating these patients. Lidocaine, not something that I at least have ever really thought of for neuroprotection, actually does reduce the metabolic rate of oxygen in the brain at induction doses. But we want to make sure that we avoid higher doses, as higher doses can induce seizures. It also is very beneficial for induction, as it does blunt that hemic response. So it helps maintain a normal ICP and doesn't allow an increase in ICP during things like intubation. Dexmedetomidine, a medication that we don't use that often here, but can be quite beneficial in patients with ischemic brain injuries, as it doesn't really change the metabolic rate of oxygen, but it does decrease the cerebral blood flow into the brain. It also is very beneficial in that it's a sedative, it's an analgesic, and it can cause a lot of anxiolysis without causing that respiration that we worry about with benzodiazepines. It also is useful for general anesthesia, as you'll see volatile anesthetics aren't the best for the brain, and so dexmedetomidine allows a lower dose of volatile anesthetics to be used, which means that you're using less of a medication that's bad for the brain. Barbiturates are something that used to be used a lot more than they are nowadays by us. However, they can be quite beneficial, as they kind of decrease oxygen consumption, blood flow, and ICP. And they, again, maintain the vasoregulatory response to the CO2. Like benzos and propofol, they're a good anticonvulsant, and they have this inverse steal phenomenon where they actually cause vasoconstriction to the healthy areas of the brain, which means that there's preferential blood flow going to the ischemic areas, allowing more blood to get to the areas that need it. They're also very useful in patients who are refractory to other therapies with high ICP, as they can allow you to have a barbiturate coma, allowing the brain time to heal from the insult that it's experienced. So the bad, or the more neutral medications on this list, are inhaled anesthetics. Each one is slightly different, but for the most part, they all increase cerebral blood flow and ICP, as they cause cerebral vasodilation, so they're increasing the blood going to the brain. But they do decrease the cerebral metabolic rate of oxygen, which is good. They, again, maintain vasoregulatory response to changes in CO2. They, however, impair autoregulation, so our brain's natural protection is kind of blunt with these. So it's not as beneficial, as your brain is unable to protect itself, and we need to do a lot more to try and control that. Unfortunately, they increase cerebral blood flow while decreasing oxygen consumption. So this can cause a steal phenomenon, not a reverse steal phenomenon, which means that you have increased blood flow to the normal areas, and that decreases blood flow to the ischemic areas, as they were already maximally, and therefore it steals blood from them. This hasn't been really proven, so if it's not real, then potentially you can get increased blood flow to these areas as you have higher CBF, but they're best to be avoided if you can in patients with severe brain ischemia. Opioids are more neutral in that they don't really change your oxygen consumption, blood flow, or ICP. And they do maintain vasoregulatory response to CO2. Now, if you're using opioids in an awake patient, they can be detrimental in that they, as we all know, cause hypoventilation. And with hypoventilation, you get hypercapnia, which causes an increase in CBF. And some of them, mainly alfentanil, have been shown to cause seizure foci and should therefore be avoided in any patients that you're worried about seizures. Now, when waking patients up on these medications or trying to examine on these medications, it can be difficult to get a good examination, given that it does cause a lot of sedative effects. And so it can be difficult to determine whether or not the sedative effects are due to the medication or due to some insult that the brain has experienced. Now, the ugly medications that definitely should be avoided with ischemic brain injuries. Ketamine, number one. So it causes increased cerebral blood flow, increased ICP, with very unchanged oxygen consumption. So this isn't good, as you don't want an increased ICP with brain injury. You're going to get less oxygen delivery to the areas that are already ischemic. Again, it causes autoregulation to be abolished, so that brain's natural protection doesn't have that anymore. And it's actually been shown to increase seizure activity with this medication, so definitely should be avoided in patients who are concerned about any sort of seizure activity. And it can further increase ICP in that it actually decreases the absorption of CSF. Now, with using this with other medications, or if you are inducing somebody, it's not necessarily going to increase your ICP to the same extent as you can cause them to breathe at higher rates in order to decrease their CO2 and decrease the cerebral blood flow to try and counteract the increase in ICP, but it is still best to be avoiding ketamine in these patients. Nitrous oxide is another one that is best to avoid, as it causes an increase in oxygen consumption as well as cerebral blood flow and ICP. You can, like with the last one, pair it with some hypocapnia in order to kind of attenuate the increased ICP, but it is very bad in any procedures where you have the skull open, as we all know, yet venous air embolisms. And with nitrous oxide, if it gets into those spaces, it can enlarge any air embolus, making the situation a lot worse, so it should be avoided. Now, Etomidate, a medication that we don't really use here, isn't really useful in patients who have ischemia, as it can be associated with cerebral desaturation. So even though it does decrease the cerebral oxygen consumption, cerebral blood flow, and ICP, it's still not a good choice in patients, especially since some seizures and myoclonic activity have been seen in some studies with this. Really, the studies haven't shown that there's any beneficial effect to Etomidate, so we don't use it. We shouldn't start using it for these patients. Here's a good table just to kind of summarize everything that I've gone over, something that you can maybe have in your back pocket if you ever are wondering, which medications should I use for these patients. This can be very helpful. And here's my references. Thanks, everyone.